Poor communication in a healthcare setting can not only lead to mistakes being made, but also to serious injury, disability, or death. This is why our group has chosen to focus on the National Safety and Quality Health Service Standard 6, Communicating for Safety. Our proposal is the introduction of an electronic handover system that will aim to reduce clinical errors by 15% within 6 months of the launch of the program. Throughout the Learning from Error video, it was noted that there was continuous breakdown of communication due to ineffective or non-existent handover within the entire healthcare team. These cumulative errors resulted in adverse effects for the patient. The accurate relaying of patient information is crucial in providing effective patient safety. Poor handover of information poses an increased risk of errors occurring. Effective handovers are vital to patient care. The current handover techniques that are practiced within Australia allow for miscommunication between staff, resulting in a higher chance of errors occurring. To improve patient safety, there must be a change to current practice. Using a structured approach to deliver handover ensures crucial information is communicated and patient safety is increased. Till, Sell and Wilkinson in 2014 successfully implemented an electronic handover system, Dr. Handover. Our proposal will be based off this, but will be rebranded as Nurse Handover. Nurse Handover connects with the hospital's current patient management system and will systematically structure the handover process using the ISBAR format, allowing for a clear, concise, and easy to follow process of communication. ISBAR structures content, minimising the opportunity for omission of information. Utilisation of ISBAR format to hand over information was implemented with the aim of standardising structure of clinical handovers to decrease errors caused by ineffective communication. Furthermore, upon completion of handover, a digital receipt will prompt both nurses to electronically sign, indicating they have participated in handover and that the oncoming nurse accepts responsibility of the patient. Ryan, Auden, Tiani, and Conlon and Ridgway in 2011 explore the benefits of electronic handover. The study concluded that the benefits of effective handovers reduce the mean length of patient stay by 1 to 2 days. This is due to accurate translation of patient information between clinicians, reducing the risk of omission of pertinent information, resulting in decreased complications during a patient's stay in hospital. Furthermore, the study discusses the development of an electronic handover system is user-friendly, cost-effective, and time-efficient. It is evident that the implementation of electronic handover will decrease the amount of errors occurring within a clinical setting. The process will be measured using qualitative and quantitative data received from auditors, VIMs, and patient and staff surveys. This data will be analysed prior to the commencement of the process and the end of the 3-month trial period. At the end of the 3-month trial, data analysis will indicate what improvements can be made and implemented before commencing the trial for a further 3 months. Implementing structured handovers will reduce miscommunication that result in clinical errors. These changes will enable healthcare staff to provide safe and effective care and implement a multifaceted approach to clinical risk management, providing additional stages in the process of error risk management. Finnegan, Marshall and Flanagan in 2010 show the importance of effective clinical communication, and failure to hand over clinical information presents as a major factor in 60 to 70% of serious errors. In order to obtain funding, the hospital administration and board would be approached with a clear proposal in place outlining what nurse handover is and how it will reduce risk and have a positive impact on patient care. Once approved for funding, Phase 1 will include Cotter's 8-step change model that has been chosen to guide planning and implementation of nursing handover. Cotter's model was chosen as the foundation for the proposal as it is proven to positively shape change whilst acknowledging that staff have a huge impact on the result of change and allows for staff to be inclusive as the driving force. This model encompasses 8 steps for altering workplace systems: create urgency, build a guiding team, develop the vision, communicate the vision, empower action, create short-term wins, build on change, and make change stick. It is essential that staff are shown data directly relating to the risks involved in patient handover, therefore providing them with an understanding of the importance of this vital change to processes. Nurse handover will be announced in weekly newsletters, staff meetings, and at huddles prior to handovers to bring awareness prior to launching. 2 nursing staff will be allocated as project leaders who will receive extensive training before the launch to aid in transition and be a go-to for other staff to seek help when using the program. Phase 2 of implementation will include the initial 3-month trial period, after which staff and patients will be surveyed on how they felt the program enhanced their care. The decision to implement the proposed change within a subacute ward rather than acute was due to patient turnover not being as high, meaning the patients will experience more handovers, thus making the patients a vital part of the evaluation process. From this, the patients surveyed and interviewed will be able to give a more accurate information about how they felt the implementation changed handover. Patients will have an opportunity to reflect both before and after implementation of electronic handover and will be able to discuss with surveyors if they felt they were more included with the process and if their care changed. Phase 3 will include re-evaluation of data and making further changes and plans based off the surveys conducted during Phase 2. Accurate handover of patient information is fundamental to continuity of care, patient safety, and reduction of clinical errors. Measuring the effectiveness of the handover process can provide the clinician with an understanding about which areas may need improvement. The effects of the changes and interventions of the electronic program will be measured through interpreting and analysing data gathered from an auditor. The auditor will be rotating during trial periods to ensure the program is effective, that staff are compliant, and that staff are being supported throughout the process. Information gathered from VIMS before and after the trial periods will enable analysis of data to make any improvements necessary of the new electronic handover process. Conducting audits highlights how electronic handover improves the quality of information passed between clinicians. The involvement of clinicians is essential to developing a sustainable electronic handover system. By actively involving patients and staff in surveys, an accurate measurement of the electronic program can be made and can assist in identifying any improvements that need to be implemented. Patients are the common link in clinical handover and should be included in current policy review and actively participate with the improvement team whenever possible. VIMS will identify errors that occurred in the subacute ward before and after the 3-month trial of the nurse handover. This information will be useful to measure the effectiveness of the program and will also measure overall success. During the initial months following the implementation, feedback should be sought to find ways to improve the new electronic handover system. The effectiveness of nurse handover will be monitored through establishing a baseline of the communication errors in handover and where improvements need to be made. To record the effects of nurse handover, a suitable committee would be established to be responsible for monitoring, interpreting, and reporting on data collection. This would include risk management reports, results of surveys, and percentage of handovers carried out according to the nurse handover. Clinical staff on the wards would have the opportunity to feed back the effectiveness of the new system and the impact it has had on their work schedule and patient outcomes on a day-to-day basis. The established committee would gather the information obtained as above, analyse the data, and submit a report recording all results. Training sessions will be organised for staff to undertake prior to the implementation of nurse handover. In addition, new staff would be required to undertake mandatory training. Training ensures familiarity with the program and provides an opportunity for questions or concerns to be raised. Education will encourage staff to provide appropriate and relevant handovers when on the ward. Furthermore, the use of the team leader will encourage staff to seek assistance if they have any further concerns once utilising the program on the ward. Nursing staff will be required to participate in a short survey at the end of each trial period to gain feedback on effectiveness and highlight any changes required in the future. Throughout the trial period, patients will be provided with an opportunity to participate in a questionnaire to gather data on how involved they felt during handover. This will allow various data collection throughout different stages of nurse handover implementation and can indicate whether there is an improvement in patient involvement during handovers. Audits will be conducted at 3, 6 and 12 months to assess that nurse handover is being utilised appropriately and consistently in line with hospital policies and procedures. Data analysis will aid in implementing changes for future improvements and long-term success of nurse handover. Ongoing funding will be required to ensure long-term success of the entire program. Funding will be used for training of new and current staff, audits, and any changes made to the nurse handover. A study by Hunter and Oakley in 2017 shows there is a decrease in errors and effective communication increased after implementing an online system for handovers. At the end of the successful trial period, nurse handover system would be implemented throughout the entire hospital, where wards will undertake similar training and education sessions in conjunction with allocating a team leader to assist new staff. Our hope is to create a safe and comprehensive tool for nurses that not only saves time, but also saves lives.